So I'm going to be speaking about how we've used the Mass Highway to satisfy our meaningful use requirements for Stage 1 and Stage 2. And I'm going to give you specific examples so that hopefully you can take this back home to your organizations and implement some of these as well. Just first of all, Reliant Medical Group, we're a large multi-specialty group practice throughout central Massachusetts. In this area we merged Fallon Clinic and Southborough Medical Group. We now have over 500 providers. We take care of over 300,000 patients. We don't own a hospital. None of the hospitals own us, so we're an independent group practice. And we've been live on electronic health record for 8 years now. And we 99% of our providers passed Stage 1 of meaningful use, 90% passed Stage 2 of meaningful use last year, and this year we expect close to 99% will pass Stage 2 of meaningful use. So we're on track for that because obviously we're measuring it during this quarter. And there are 4 things that the Mass Highway does for us to help us. Well, more than 4, but there are 4 measures, objective measures, that we use the Mass Highway for to satisfy meaningful use. We use it to help us perform medication reconciliation. We help us with the public health reporting measures. We use it for the transitions of care summary document measures. And we use it for the transmit piece of the view down and transmit that patients are supposed to be able to do. So first of all, med reconciliation. We're connected with St. Vincent Hospital and Milford Hospital through the Mass Highway. They're both in Central Mass, and when patients are discharged, ours that are discharged from those hospitals, they send a consolidated CDA discharge summary document through the Mass Highway, and it comes into our electronic health record, and it gets routed to the primary care physician, which would be me. I'm an internist. And it comes to my in-basket, so I can see the medications as well as other things. But what's also most important is that then when I make sure, because of that, I make sure the patient comes for a follow-up visit after the discharge, and then when I see them, I can look in my electronic health record and I'll see the discharge summary, the document that was sent through the Mass Highway. I can see the med list that they were discharged on, and I can see what the patient thinks they're actually taking and reconcile those. For public health, in Massachusetts, there's the Massachusetts Immunization Information System, which keeps track of all the immunizations. So what we do is we've configured our electronic health record so that at the end of each encounter, at the end of each visit, when I close it and sign it, it checks, the electronic health record checks to see if an immunization was given or entered as historical during that visit. And if any of those were done, it automatically sends a record through the Mass Highway over to the Mass Department of Public Health so that it updates the registry of immunizations for them. I don't have to do anything, it happens automatically. And that's an important thing, is that if you want something to be done reliably every time, especially by physicians, don't have them do it. Have it happen automatically. And so that's why this works so well, because no one actually has to do anything, it happens automatically. Now, CMS threw a curveball at us the first week in October, when they said everyone has to do 2 public health measures, and for physician practices, we didn't have a second one. There is no syndromic surveillance for physician practices, and so what we ended up having to do was use specialized registries. So we went out and had researched the specialized registries that were out there. And if you look carefully, almost all of the national ones are actually sponsored by pharmaceutical companies, which to me means that they're not doing this out of goodwill, but that they're going to be reusing the data for their own analyses. And I didn't feel comfortable with that, especially because you're sending all of this personal information on our patients. So, disclosure, I am the acting chair of the Massachusetts eHealth Collaborative, which is a nonprofit organization run out of Boston, and it's run by Mickey Tripathi, and we do a lot of promotion of health information exchange and electronic health records in Massachusetts. And one of the things that the eHealth Collaborative has is this specialized registry. So we're submitting our CCD summary documents at the end of each encounter. We automatically submit them to the Massey Health Collaborative through the Mass Highway, and they give us quality reporting, so that satisfies the specialized registry function. Again, I run that thing, so I just want you to know, look around, decide what you want to do, but it's actually a pretty darn good deal and an easy way to pass that second public health measure. Transitions of care, they're important. We want to be able to send summary documents, so whenever one of our patients is transitioned from one place to another, we want them to know about the patient. So we've configured our electronic health record that whenever I put in a referral for some outside physician, as part of the referral, asking, well, why do you want this person to go see this specialist? It also says, please send a summary document, tell us where to send it. And what we do is we click on the button, and also it says, and make sure you get the consent for the Mass Highway. And then when you pick on the destination that you want it to, the referral to be sent, it basically behind the scenes knows that when that order is signed, it will also send a summary document through the Mass Highway to the direct address that you select. And that wasn't automated, so it doesn't happen 100% of the time. And that's one of the downfalls of not setting this up automatically. But what we did do that is reliable and 100% of the time is our connection to the emergency rooms. As part of transitions of care, you can optionally include patient self-referrals to the emergency room. Now, most people don't do that, but what we did is we worked with St. Vincent Hospital and Milford Regional Medical Center, and we said, here's the list of all of our doctors, okay? When one of our patients shows up and you register them, automatically have your electronic health records send us a message saying your patient just registered here. It's called an ADT message, arrival, discharge, transfer message, and it happens automatically. So they list it in their interface engine at the hospital. Here are all the Reliant doctors. And automatically when the patient registers, it instantly says, oh, there is a primary care physician from Reliant or a referring physician from Reliant. It sends us that ADT message. And then what we did, so the message gets sent to us on our patients, we automatically generate a CCD right out of the electronic health record. We said, okay, we just got the notification, generate a CCD, and oh, by the way, the ADT message we got from the hospital had the hospital's medical record number on it, so stick that medical record number on the CCD. So we then send the CCD with the hospital's medical record number through the Mass Highway and onto the emergency room where it shows up on their bed board. 90 seconds, it takes about 90 seconds for this whole round trip, from the moment they register in the emergency room to automatically have a summary document sitting in the ER's electronic health record system. And then, they can go look at it and see it, and it's a nice little summary document. It's got their meds and allergies and immunizations and recent test results. Works very well because no one has to do anything. Now, view, download, transmit. So patients are supposed to be able to transmit their summary documents electronically to other providers, and so they can tell us, they can tell the system which of the major providers in central Massachusetts they want, and they can select it, and then a summary documents get sent through the Mass Highway to those providers, satisfying the transmit part of view, download, transmit. One of the projects that I worked on was we recognized that patients don't just go from doctor's offices to other doctor's offices or back and forth between the hospital, but they actually end up in nursing facilities, skilled nursing facilities. They end up with home health agencies, and those are transitions of care that are equally important, if not maybe even more important often. So what we worked on was something called the IMPACT Project, Improving Massachusetts Post-Acute Care Transfers. That's what IMPACT stands for. With that project, we're trying to figure out how we can get nursing homes and home health agencies to be connected. So what we did is we worked out a process. We recognized that a lot of the nursing facilities didn't have electronic health records, so we have 8 nursing facilities that are connected to the Mass Highway using a tool we developed called SEE, which is the surrogate EHR. It's like an EHR really light. And it's just a way of receiving documents and from, let's say, a hospital that's already got, here are their meds, here are their allergies, here are their problems, and allowing them to update that so that when the patient then goes home, let's say to a nursing, to a home health agency and back to me, that they can update it with, these are the meds that have been added, these are the meds that we stopped, we now know they're allergic to something, we'll add that allergy in there. And so that's what the C tool allows them to do. It doesn't really replace an electronic health record, it's just a temporary solution until they do get an electronic health record that's connected. So the way it works is that, I've got my patient who shows up in the emergency room at one of the hospitals, and as I've been doing, I send them the CCD summary document. When they're discharged from the hospital, they go ahead and generate their own CCD summary document, which they send to me, but they also send a copy to a nursing facility. And it's loaded into C. They get alerted by that. They get a text message. This is standard functionality of the Mass Highway, that you can get a text message saying, you've got mail, and they can go ahead and see it. One of the other things they do is in nursing facilities, so they use something essentially for billing called the minimum data set, or the MDS, and that is mostly, has some interesting clinical information. It's got wound status, it's got functional status, it's got cognitive status. So that's kind of useful clinical information that would be useful for the next person who sees this patient to know. So what they can actually do, and no one's actually doing that here in Massachusetts, but they could, is there's a program called the HIE transport. It's made by some folks in Pennsylvania. If you Google it, you'll see it. Its nickname is the Gobbler, because what it does is it gobbles up these MDSs that the nursing facilities are using anyway, generating automatically anyway, and it pulls out that clinical information, functional status, wound status, cognitive status, puts it into a CCD, and then it mails it right back to their own mailbox in C, so that now, when they're going to be sending the patient home, they've got the information about what the patient was on when they were coming from the hospital. They've got their latest functional statuses there, and they can use C to actually merge the information from the two and make any other updates, and then send that document on to home health agency or on to me as the primary care physician. So it's a nice tool. If that's of interest to you, let the Mass Highway folks know. But what's the future? So the future is bright. I think we're going to be doing cool stuff in Massachusetts. We're very lucky to be here. We have a very forward-thinking and group it's actually, we're one of the most effective health information exchanges in the country. And so right now we have something called the Relationship Listing Service in Massachusetts, called the RLS. And there are I believe only 4 organizations are using it right now. I know Atrius, Beth Israel, and a couple others are using it. And what it does is it says that whenever, let's say at Atrius, which is group practice in eastern Massachusetts, when they see a patient, they get the patient to consent to participate in the Mass Highway, and they send that consent information up to the RLS. And what it says is that this patient is a member of Atrius. They're cared for by Atrius, and they've given permission to have a connection with Atrius, that this is, it's okay that other organizations know that they belong to Atrius. And then when that patient goes to Beth Israel Hospital, Beth Israel does the exact same thing. They register in the emergency room. Beth Israel sends a message, get the consent, and sends it up to the RLS. And now that patient's record says, okay, this patient goes to Beth Israel, and they go to Atrius. Well, and that's how they show, basically we're listing all these relationships. So you'll be able to find out where the patient goes and gets their care. Well, the next cool thing is that you can use that to subscribe to events. So for instance, let me show you an example here. So that's me again, in a few more years, the balding guy. And I register a patient, and I let the RLS know that this is one of my patients. But what we'll be able to do in the future is say, not only is this one of my patients, but I want to know everything that happens about this patient. I'm going to subscribe to the information about this patient so that I want to know when they go to the emergency room. I want to know wherever they go so that I can care for them. I'm part of an ACO, I'm responsible for these patients, and I want to make sure that I can give them their best care. And it may be other places that do that as well. For instance, the long-term services and supports folks, and the aging services access points. These are, the people that bring you Meals on Wheels and home care people. they may want to know when patients are admitted to the hospital so that they don't try to go to their house when they're not home. Same thing with home health agencies. They may register their patients so that they get told when their patients are admitted so that they don't go, because that's a big problem. They go to the patient's home and no one's there because they were just hospitalized and no one bothered to tell the visiting nurses that they're not at home. Or maybe the home health agency ought to know that the patient was seen in the emergency room and sent home, so that the next day they make an effort to show up and actually visit the patient the next day to make sure that they're safe at home. So these notifications could be very useful. So they register and sign up for a subscription to be able to get notified of these events. And something that we're hoping to work on is that the ambulances could do the same thing. When an ambulance is dispatched to one of my patients' houses, I could be notified from the RLS with the event notification that one of my patients just had an ambulance called, and I can send them a summary document, just like I do to the emergency room. I can send them that summary document right to the ambulance before they even get to my patient's house, so that when they show up and try to care for my patient in their home, they'll actually know who this patient is and what meds they're on and what allergies they have and what their problems are, and they can provide more effective care in the home. They might even be able to do some care in the home so that they don't even have to take the patient to the emergency room. So imagine that, that not every patient has to go to the emergency room when the ambulance is called. So this might be better care for our patients and maybe actually save some money. And so and this can go on further. So when the patient shows up in the emergency room, again, that triggers me to send a summary document to the ER so that the ER knows what's going on. And that and also the fact, as we talked about, the fact that they're in the ER admitted to the hospital can notify home health or notify the long-term services and supports folks that whether or not they should be going into the home the next day. Nursing facilities can be tied into this, and it can be a wonderful world where people are caring for our patients and they actually know what's going on. So I think the future's bright, and fortunately the Mass Highway supports a lot of the future as well as what we do today for meaningful use. And thank you.
I'm going to be using my time to complement, I hope, the good doctor here I'm going to spend a little bit less time on use cases. I'll tell you a little bit about them, and I'll spend a little bit less time on use cases than about the effort that went into making our activities possible, the administrative work that we needed to do, the relationships that were helpful to us. My hope was, rather than being impressed with our use cases, to come away with some understanding of what effort would be required on your part if it was your interest to try to replicate any of these use cases. Hopefully that's useful to you. Oops, that's my own slide. So, Highland Management. We are a private HIE, and of course HIEs are defined in lots of different ways. You can think of HIEs as being entities that provide direct messaging services, or you can think of them in terms of entities that house repositories of information, or you can think of them in terms of record or relationship locator services. There's many different kinds of ways to think about that umbrella of HIE. So at Winchester, we are a private HIE. It's Winchester Highland Management is actually a joint venture of Winchester Hospital, which is now a proud member of Leahy Clinic, and a Independent Physicians Association. We have a little bit about our community, because I think this kind of matters. We think we are pretty typical of other organizations across the state. We're made up of about 400 hospital-based and independent practicing physicians, PCPs, and surgical services. We have roughly 24 EMRs in our community. So in many ways, we are not atypical. We have 98% overall EMR adoption. of the 24 EMRs that we have in our community, about 65% are accounted for using these top vendors. And this is important as I go forward, because as I try to describe what we're doing, it's important to understand that because of the size and complexity of the work that we are all engaged in, that you understand that you don't have to go big bang with all of your vendors at once. In fact, it's not possible. It's not physically possible, it's not technologically possible, and you want to preserve your teams. So what I want you to understand is that our health information exchange has two independent but complementary functions. We support direct messaging, and we have a longitudinal patient repository. So our intention in the long term is to allow all of our providers, regardless of where they do their work, to be able to function within their EMRs. We expect that most of, if not all of the EMR vendors will support direct messaging using direct trust protocols within their EMRs. And it's our intention that they will also be sharing CCDs nightly up to our repository. And we're working through our biggest list of EMR vendors and progressively trying to reach out to the rest. Each of those functions is intended in the near term and the long term to both integrate fully into their EMRs, both the data exchange of CCDs and the direct messaging, and also to work independently using a web-based utility. That's important because we fully expect that in the near term, there will be many vendors that will not be able to pony up and provide full integration of both, well, either or both direct messaging or CCD, full CCD exchange into the notes themselves. So this grant was particularly important for us because not only were we able to build some good relationships and establish some credible use cases, but we were able to thank the Home Care Association of Massachusetts for an innovation award that we were very happy to receive. Occasionally people say, good job, and that made us feel really good. So our goal was pretty straightforward. Our intention was to try to demonstrate that we could entice patients and their families to increase the use of home care services as substitutes for skilled nursing days. And we targeted patient groups that were likely to want to hear about home services for post hip replacement services. The strategy for us was very simple. We wanted to use direct messaging to allow the surgical services, in this case the independent surgical practices, to send referrals directly to the home care team so that they could then reach out to patients directly, patients and their families, to invite them into educational workshops so that they could understand the options for home care services that would be available to them post-surgery. And then the other piece of it was because we believed that timeliness was important if we were going to have any interventions that were going to be meaningful for us. We thought that not only were we focused on the timeliness of getting patients connected to home care so that they could have education early, but we also believed that it was important to have exchanges of data back and forth with the surgical services department. In the next slide, we're going to take you through. In this case, it was pre-admission testing and surgical scheduling. because we didn't want to lose people in the process. So we, focusing first on pre-admission testing, we made sure that all of the pre-surgical booking and testing were transmitted directly between an eight physician surgical practice and both pre-admission testing and the surgical booking services themselves. This was particularly successful for us internally because one of the things that it did was it allowed us to reduce the number of surgical rebookings that frequently occurs within many hospitals day of surgery. So it will happen many times that people will, within a couple of days of surgery or the day of surgery, will present for surgery and all of their surgical booking pieces are not in place. And so it requires a lot of disappointment and rescheduling and lost surgery time, and that was extremely important to us. So we were able to reduce the number of reschedules, and we were able to speed up the time that it took to complete the pre-admission testing process and the surgical booking process. Then home care. It was important to us that we quickly be able to connect patients and their families for educational services. And in the end, it did a couple of really important things for us. It increased the number of patients and their families who attended the process because we captured them quickly in the process. There was very little delay between the time when they saw their surgeons, who talked to them about it, and then the follow-up. And then the other thing that happened was we were able, ultimately as an outcome, we were successful in substituting home care for skilled nursing facility days. That was a big deal for us, and we were grateful for that. Then the other thing that happened was because we were in the process of transferring information as an add-on to the project, this was not part of the original design, but as an add-on to the project, we decided to send home nursing notes back to the surgeons. And then, of course, they were forwarded to the PCPs. So what that did, of course, is it created a nice, well, if you think of it in transition of care, it created a nice closing of the loop, right? Because that's the term du jour now. The closing of the loop between the home care folks and the PCPs and the surgeons. What it did for us, in addition to making everybody feel better about the experience, it also allowed us in some limited moments to be able to catch some possible readmissions, because we were able to know from home care services when people were not having a good time at home and when they might likely wind up bouncing back into the ED. So that was brilliant for us, and we were really grateful for that. So what I'd like to do now, so the use cases, they worked out really well, and we're proud of those, but what I'd really like to do now is I'd like to talk to you a little bit about the mechanics. How did we get from here to there? The first thing that we did was acknowledge all of our stakeholders. We brought them into the process, and we tried to understand exactly what it is that they needed us to know. So we had our patients, we had PCPs and surgical specialists, we had our hospital surgical services and our home care and our ACO care managers. MeHI, EOHHS, the highway onboarding team, our various EMRs, our HIS vendors, and never forget your attorneys. So among the end users, we're really talking about physicians and hospital and clinical related people. Hopefully I'm speaking to you because this is your world, right? So it was important to our practices that we support them in capturing meaningful use dollars because they wanted to attest saying that we are using direct, we are using secure methods for transmitting information back and forth. Also, we're very concerned about HIPAA. The other thing that the physicians really wanted to make clear to us was that they needed a couple of small things in response. They needed to, in return for this effort that they were going to put out, they needed to know that we were going to try to help them put a cap on the excessive administrative burden that they anticipated feeling because they were asking to do something more than their regular job. They asked us to make sure that that we engaged with them to try to create the fewest number of clicks possible. That was really important to them. They wanted to make sure that traffic, whether it was CCD information that was being exchanged through our repository, which is another story, or direct messaging, was integrated fully into their EMRs because they did not want to leave their EMRs. Very important. This may have been their number one issue. And then they wanted to make sure that because we were creating a repository, a second layer, really a layer of application, that we worked with our vendor, our EMR vendor, our HIE vendor. In this case was eClinicalWorks. We interviewed 14 different national vendors and we picked eClinicalWorks. It was coincidental that they're one of our biggest EMR companies. But they wanted, as we got into this, to have an option to be able to use direct messaging fully integrated into the web-based version of our HIE. And that was really important to us because we anticipated that early on, many of our EMR vendors with their HIS partners, assuming that they even had HIS partners yet, right, because this was a couple years ago, that they would have the ability to transmit CCDs back and forth, even if they didn't have a direct interface between their EMRs and the repository, that at a minimum they could, if it was living in the repository, they could send it in and out using direct messages. This was big. So, moving forward, highway participants. I have to seriously, I will continue to applaud the highway and all of our state partners for the work that they did in helping to make this possible. In the original version of the highway, it was not anticipated that it would allow for HISP to HISP relationships. It was really focused on accepting the state root certificates for the purposes of verifying identification and creating security. It was a reasonable and easy conversation to have with our state partners to say, look, we have many different EMRs out there that are already in the process of building direct messaging into their EMRs. They have HISP partners already who are becoming direct certified. And so what we really want to do is we want to use the opportunity of this grant to extend the reach of our partners, right, because our hospital is using highway accounts, whereas independent physicians were using EMRs that wanted to use their existing HISP vendors. So what we wanted to do was we wanted to make it possible for highway users to extend their reach beyond other highway users out to independent EMR companies that were using their own or their partnered HISP direct accounts. Fair enough? So what the state did with us is the attorneys worked with us and we created a very different kind of a model than what was originally envisioned. It required a couple of different things, a couple of different accommodations had to be made. So because we were already in the process of developing a repository, we had to have some agreements with all of our different independent and employed practices that said that these are our agreements when we work with each other. This is how we're going to use the information, this is how we're going to safeguard it, we're going to have cyber liability insurance to protect each other and the rest. So we had participation agreements already in place. What the state did for us was they reconceptualized how they got started, and they said, all right, rather than having every individual physician and hospital sign a state participation agreement, we are going to deem them participants if they have signed your participation agreement, because we have worked with you to modify your language to sit with ours. So there was some effort, and we applaud them, because it was a lot of heavy lifting, and they did a great job. They never pushed us away. They were very welcoming. We really have to be grateful to them for that. So as of right now, we have independent vendors and organizations that are able to sign participation agreements. Vendors now sign their own vendor participation agreements, and that works out really well. And I guess I talked ahead of that slide. So now they work ahead and they negotiate all the root certificates up front. Because the highway requires patient consent, we had another level of conversation that required some out-of-the-box thinking. We already required, because we have a repository, that every patient should sign a consent form. And so what we did, and what the state was good about doing with us, was they agreed that we would take the Mass Highway patient consent language and we would integrate that into ours. So what we now have, instead of having, some practices will use more than one consent form, and some have consolidated them into these universal forms. So they consent to treat, consent to bill, consent to send information over the highway, consent to allow your information into the repository, and they create one omnibus universal consent form, and that works for them. And that was terrific for us. The other thing that we do is we have one central registry for collecting patient consent. And EMR companies work with us. We try to develop our ADD interfaces so that those consent change flags can go back and forth, so that a practice management system can register a yes, an opt-in consent, or an opt-out consent. And that flag will go into the repository, and if possible, if they are capable, they can receive it back, and it should show in the receiving entity's registration screen. That was a lot, but thank you. So we were successful, as I said, in redirecting SNF stays. We felt really good about that. The other thing that we started doing was we started, as an institution, examining the possibility of extending out to non-pilot organizations. And so we have begun the process of looking at additional surgical services, additional surgical independent surgical practices, and moving forward with that. We had a number of activities that were pre-planned prior to the grant application, and so there were a number of activities that were ongoing and concurrent, and then there have been a number of activities that we've continued on after the period of the grant. As I mentioned before, one of the important add-ons for us was the transmitting back and forth of nursing care nursing notes. That was really big for us. We're now experiencing success because PCPs and surgeons who were part of the initial experiment started talking about this with their colleagues, and we have expanded the use quite a little bit. We are now sending admit and discharge notifications out of the hospital to our PCPs, and if there are surgeons or non-surgical specialists that want them, then we're happy to accommodate them as well. We're moving right along. I just want to keep an eye on time. You're going to get this packet, so you'll be able to read a lot of this yourself, but I do want to get to questions and answers. This is really more about the same, our trying to expand interest in the use of the highway and admit and discharge notifications, the transferring of patient information to support care. In the interest of time, I'm going to move a little bit through this. There were a few things that I think are worth mentioning here. In working with the various vendors around data repository, it was important for us to feel like we could share with you a few basic truths. That the amount of variability in the functional requirements that exist across vendors when it comes to the creation of a CCD document, CCDA document, and the transmitting of, there's an incredible amount of variation in that. What we realized, and what I think is important for anyone in the audience to realize, is that just because you have agreed to, say, a C32 compliant CCD as a format, doesn't mean necessarily that every component of that CCD or CCDA will be what gets transmitted. Having said that, just because it can be transmitted doesn't mean it can be generated or consumed by an EMR. Very important. So we have been working with EMR vendors to try to make sure that their capacity to generate and consume these documents and to improve the number, the segments that were complete and transmitted or consumable was that we were increasing that capacity. The other thing that we did that I mentioned was we were trying to work with our HIE vendor, in this case ECW, to allow us more options for exchanging information back and forth with other vendors that that were not at the same level of being able to transmit and receive. And so part of what we did was we worked on, like I said before, the concept of sending and receiving via direct. It takes us now to this. Just like with creating interfaces with a repository, similar problems were encountered by us with direct. There's a great deal of variability that exists among EMR companies and their HISP vendors when it comes to being able to send text message, the text within a message, the CCD attachment, PDF attachments, usable Word documents. The EMR company, whether they can generate them or consume those documents aside, it's not true that all of the HISP vendors can transport those items back and forth to each other. So what I'm really trying to say to you is this. When we were building our repository, and we, of course, had this epiphany that vendors, EMR vendors themselves were having trouble consuming, generating and consuming these documents, then, of course, we realized that the HISP vendors were somewhat limited in the types of documents, the payload, that's actually how it's referred to, the types and the size of the payloads that they could carry back and forth with each other. So there's been quite a little bit of work that's been done around that. I would applaud again the highway onboarding team for helping us to reach out to EMR companies and their HIS vendors to try to resolve some of these technical problems. That is largely my presentation for now. I want to thank you for indulging us, and we'll take any questions you have.